sort of educational WebEx series looking into watchers, what it is, why we do it, why we should be thinking about doing it in all areas within Scotland, and what we can learn from people who are already doing it, and what we can learn from people who are thinking about bringing it into their ward environment, and why we should do it. So the actual title of the talk is Wire 3 Every Time, and hopefully that will become obvious at the end as to how we deal with very complex systems and very complex socio-technical systems, and we work in a very complex system, that being healthcare, where humans interact with humans and machinery and infrastructure, and there's a lot of rich information out there, particularly from people, that we don't use, and so how do we manage to get that increased amount of intelligence from people at the front line about children who are perhaps not as well as we expect them to be, or there's something about them that is causing concern and could potentially be escalated in a manner that avoids any further harm or deterioration and escalation, etc. So that's what really sort of this is going to be about. It's about how do we improve our system using the frontline staff in an appropriate way. So as we've been talked before, but I'll go over it again. The reason that we chose some of the things to look at, particularly PEWS, was because of a study that was done a couple of years ago, and there's been a number of papers subsequent to that describing the mortality rate of children within Europe. And it was quite surprising, particularly for people in the UK, because particularly in the children who are under 5, then the death rate is probably one of the highest in Europe within the UK. And that kind of staggered us a bit because obviously we're a country that has got a national health service, it's got a lot of people working for it, it's got a big population, we get, despite what the papers say, quite a lot of money to make it work. And we have several significant advantages over other countries, and yet our death rate was higher. And compared to Sweden, it's quite worrying because Sweden has a smaller population, it has a very dispersed population, such as Scotland, but it has the same proportion of money given to the health service. It has roughly the same diseases, it has roughly the same patient demographics. There's no different antibiotics, no different levels of care, and there's no different, diseases or bacteria or whatever, and yet the death rate is significantly higher. So what we kind of already knew with this subsequent paper was that the UK has high child mortality rate and Sweden has a low child mortality rate. And prematurity is a major cause of that, particularly in children less than 5. And there's obviously social inequalities that contribute to child mortality and prematurity, which we're acutely aware of, particularly in the west of Scotland, and has been one of the triggers for the early years collaborative. What this paper helped with was it identified that the rate of infections in children were actually significantly higher in the UK than in Sweden. So sepsis is a bigger killer and it's more obvious, and that's obviously one of the things that we've incorporated into the PEWS chart to make people aware of, could this be this sepsis or why isn't this sepsis? But the majority of those infections weren't weird and wonderful. They were the same types of infections that were in Sweden, and they're equally as treatable, and the bacteria were equally as susceptible to antibiotics, and yet the death rate was higher. So what was it that we were doing differently, and were we missing things? Was our system not allowing us to use the people's sort of clinical acumen at the front line to escalate appropriately when there was concern about the child that they were dealing with? And so it was the thought that we should be looking at sort of focus on service delivery rather than accessing new medicines, which weren't going to make any difference because the bacteria were susceptible to these medicines anyway. So we have a higher death rate than anywhere else in the UK. A comparable system like Sweden does better with regards to picking up children who are sick earlier and subsequently have a lower death rate, even though the resources they have are the same. So there was this came out recently, it must have been about 3 or 4 months ago, maybe in March, the Epoch study, which is an amazing study. And it looked at, I think it was 145,000 discharges. Now for pediatrics, that's a stunning amount of children that they managed to gather. And what they did was that they had some that had were studied with a PEWS chart and some without. And the plan and the thought was, well, if we've got children who have got a PEWS chart, then surely we'll pick up children earlier who are deteriorating, and the overall endpoint will be less children who deteriorate and die. So the outcome was death in children and the difference. And they felt pretty sure that the PEWS chart was going to make a difference, and of course we felt pretty sure that implementing a national one will make a difference. And the answer was there was no difference at all, none. Now, part of the reason for that was that they powered the study incorrectly. They thought that they were going to have around about a 4 to 5% death rate, but in the years that they were looking at this study, then the death rate came down, and in fact they only had a 1% death rate. So that kind of no longer was a useful marker of whether a PEWS chart was going to be any good or not. However, the editorial was quite interesting because they said, well, if you look at the secondary outcomes and the secondary measures that they did, they also looked at events on the wards and increasing admissions to, PICU. And what they found was that there was an improved escalation to intensive care. So these children were there was a cohort of children that were being picked up quicker and were being recognized and escalated. So it sounds as though that we're on the right track with regards to the Scottish PEWS, because, whilst we have more deaths than in Sweden, we don't have that many deaths, so fortunately. So is that a good marker of an intervention? And so we're looking at, escalation, children being appropriately moved into a different level of care at an appropriate time, and one of those things is going to be looking at ICU admissions. But was it due to the number on the PEWS chart? Remember, we've talked about the PEWS chart before, and it's perhaps not the actual number that counts, it's all part of a wider system. So is there something else that the PEWS chart allowed, and was that just able to ask questions to think about whether this child could be deteriorating? What is the appropriate escalation plan? Who is listening? How are we going to bring expertise to the bedside? And could one of these things be just, talking about gut feeling about children? So their recommendation was to keep looking at the big data, so the big numbers that are coming through. But my contention is that we should also be looking at the small data. And the small data basically encompasses qualitative stuff at the front line. So that's how we interact with each other. Because we know that the amount of deaths in PICUs of children are coming down, and what we're left with is that we are having increasing morbidity, and that morbidity can be lifelong, and that morbidity can create financial pressures, social pressures, physical pressures, psychological pressures, which are lifelong and not just contained to the child. It can, it can spread throughout the entire family and beyond, and has an immense toll on the wider social circle and society itself. So by picking children up earlier, can we also think about decreasing morbidity and lifelong problems that these children face? Because, patients don't suddenly deteriorate. Healthcare professionals suddenly notice, and this is a great quote from Pat Brady. There's a WebEx from him, which we did about a year ago. It's on the SPSP site, and he gave a great talk about deteriorating patients and watchers, and I'll come up to up in a second. But he has this quote that, and he's absolutely right, it's very unlikely that children are suddenly going to go off. They probably are showing signs of deterioration earlier, which may not, and the PEWS chart might not be, sensitive enough to pick it up, but a pair of experienced eyes will. And I suppose it's kind of thinking, well, what can PEWS do, and what can our system do? And this is a nice slide again by Pat, who shows that as time goes on, the deviation from anticipated recovery, if not picked up, can lead to cardiac arrest. So the systems that we put in place are, particularly the PEWS chart, which can pick up an early warning score. So you can try and bring that area of recognition to a smaller arrow. So you can therefore try and deviate them back onto the anticipated recovery green arrow quicker, and that will lead to less morbidity, mortality, etc. You'll notice, however, there's the early warning score in the center there in the blue box, and then beforehand the systematic identification and mitigation, and underneath is the kind of the less playful with the parents. So there's something in this box and this area which is still, fairly untapped, and our sense is that might well be where people at the front line have an idea that there's something wrong with this patient and needs to escalate it appropriately. And through the medium of bringing expertise to the bedside, maybe the deterioration can be mitigated earlier, or maybe the deterioration may not happen at all. This is a great paper by Damien Rowland. He has also done a WebEx for us kindly last June on PEWS charts. Again, it's recorded and it's excellent. And he talks about sort of why, didn't you think this baby was ill? And the fact that we kind of rely on historical ranges of heart rate, blood pressure, etc. But we shouldn't really be treating children as a kind of a normal range. It's, and yet we have this massive pressure not to admit children, but at the same time not to miss anything. So these children have to be interpreted within context and trended, which is part of the beauty of the PEWS chart. But not only just to be trended through a number, but trended through a greater system, and that system is pairs of eyes, looking at the child from the end of the bed, because as you well know, the child can sometimes be, significantly different when looking at them from the chart that you have been looking at or hearing about remotely from the child itself. And so there's many sort of diagnoses that cannot rely on decision tools in pediatrics. And he's got this nice schematic, and it's pertinent to sepsis, but it could be any disease. And he quite rightly talks about a sepsis spectrum. It's a syndrome. It's got many different sort of parts to it, and we can recognize the child who is pretty well and is unlikely to do anything daft. So you probably don't need to treat, and it's very likely that no harm will come from making that decision, and many people can make that decision. At the other end, then, there is the child who's come in, who we've all seen moribund, perhaps the meningococcal, pale, tachycardic, somnolent, responding to parental intervention. And again, that's something that most people can pick up pretty quickly, irrespective of what level you are, and then intervene. So it's likely that no treatment at that point will result in significant harm, but probably most people would intervene and make an intervention. But it's the bit in the middle that's tricky, because this is the very grey area where, as again I said, that there's no sort of many decision tools in pediatrics that are hugely useful, particularly with sepsis. So who's making the decisions with regards to these children, and what is it that we can use with the information that we've got, or looking at getting more information that is out there that will help us with that. And it's trying to not have a decision tool, but having alerting a decision maker. because there's lots of experience within the individual wards around Scotland, both experience of recognizing at the bedside that this child is not well and having that sort of gut feeling, that sort of gestalt, I'm not happy with this child. And there's also expertise and experience that can help to confirm or deny your concerns and escalate appropriately. So this is the bit where the watchers are crucial, and that sort of dialogue between people who are dealing with the children all the time at the bedside, and also then escalating to get other pairs of eyes in at the right time in order to make the correct decision in a timely manner. So you kind of need to find a decision maker. You need experience to be there to make a decision. And I say it's on a spectrum, all these diseases, and it's unlikely that a number per se will help in isolation. And a lot of it is senior decision makers use gut feeling, and senior decision makers are people who are, doctors, nurses, cleaning staff, auxiliaries. All these people have been on the wards for many years and can tell that maybe something is not right. So how do we get many pairs of eyes to communicate, no matter who you are, to have better outcomes, etc. So the gut feeling is not a new, people talk about gut feeling, but it's not new to pediatrics, and I think it's particularly pertinent in pediatrics. Again, going back to Pat Brady's paper, how to improve your situational awareness. Remember, situational awareness is what have you got in front of you, what is your understanding of what you've got in front of you, and what could it look like in 10 minutes' time if the child was to deteriorate. And then crucially, the next bit after that is, well, if the child is going to deteriorate, then what could we do to mitigate that, both in terms of not deteriorating at all, but if there is a deterioration, what would it look like, and what would our next plan be, and how many people do we need to make aware of that, including people with senior expertise. So he talks about the 5 things that created anxiety within the team that led to increased out-of-hospital arrests, out of ICU arrests. So one was family concern. There's a high-risk therapies and unfamiliar therapies on a unit. There's elevated PEWS, of course, which we've got. There's communication concerns. But also, crucially, there was gut feeling. And the gut feeling, he tied into this word watcher. And that if there was a sort of a gut feeling or concern, then it was difficult to describe a patient on a board as a gut feeling. It was easier to describe the child as a watcher, somebody you would keep an eye on, because there was something which wasn't, not particularly tangible, but it was just something about this child that was creating concern within the team. So I suppose the question that we get asked a lot is, what is the definition of a watcher? And the answer is there probably is no definition of a watcher apart from somebody who is causing you anxiety, that gut feeling, that gestalt, that they're just not quite right. And remember, they can be not right irrespective of what your PEWS chart is telling you. And there's a number of, and you will have all seen it, children who have a normal PEWS, it's not budging. And but the child is dreadfully unwell or becomes very unwell. So we've come collectively up with this sort of term, which is watchers. Who are the children, with a little leading expert review, or you could have it as who are the children needing extra review. And again, that is the children who are just causing general concern within the ward, highlighted by any member of the team. And that member of the team, crucially, is being listened to as a valuable member of the team with experience and intelligence that is going to be pertinent to the outcome of this child. And watchers are fascinating because most watchers don't go to high dependency. They remain on the wards. Often they have a low PEWS score. They're quite often predictable as well, so they're bronchiolitics or cerebral palsy with a history of aspiration or a previous fitter or diabetic, and they're usually identified, crucially, by the people standing by the bedside, so that's going to be nurses and also parents. So the parents will have a gestalt concern and anxiety, so they are a very useful extra pair of eyes in order to identify that their child is not going the normal anticipated recovery line. They're veering and deviating off it. So we need to think about how to use this intelligence a bit more. And the other thing that Pat Brady uses is this great quote: "The bedside nurse does not know the plan, then there is no plan." And I think that's very pertinent, because the watcher status improves your situational awareness. But remember, we've talked before about situational awareness is fine, but if you don't actually make a plan about talking about the anticipated recovery, or what would it look like if the recovery didn't go according to plan, then what would you implement? Would that be extra oxygen, IV fluids, antibiotic change, high flow, BiPAP, anesthetics, ICU? So that was the crucial difference between when Pat Brady did his study in Cincinnati, that people could bring the children to your attention that was causing concern, remember, irrespective of PEWS, but if they didn't make a plan by bringing expertise and experience to the bedside, then it made no difference. So the crucial thing about the watchers is that everybody will know themselves that they're worried about this child, but how do we manage to anticipate what's going to go wrong and let the correct people know and have a plan? Most watchers should be and should remain mundane. They should be pretty boring. We should know through discussion what the likely trajectory is. So broncholytic day 2 might get a little bit worse, may need IV fluids, might need some high flow, nil by mouth, etc. But you can still remain, if there's on that sort of trajectory and you know that's what's going to happen, and you've discussed what your next steps would be, then they should, if they're following the plan, then they should, even though they're getting a little bit worse, then it should be still mundane. So it takes a lot of time and effort to make sure that they remain mundane. But again, it's using the information that you've got, which is already out there, and we don't use enough of the information that's out there. It doesn't take new computer systems or a bigger ward or whatever. It needs us to be able to listen to people's concerns. On the PEWS charts, we've got the area for care or concern. So if you had a PEWS of 6, then you could go and have a look at what action could be taken, and that's, as you know, is being decided locally at a local level, because the infrastructures of all the areas around Scotland are slightly different. But if there is a carer or a staff concern, then you can write C in that little box, and that can override anything. And these concerns are not restricted to, but include all these things. And the first thing that we've obviously put down is that gut feeling. Is there something about this child that is causing a concern? And it's irrespective of whether the PEWS is 6543210. And we've obviously incorporated that into our chart, of which there's 5 of them. Name, number, we've got the escalation with regards to the values there, the locally decided action be taken and level of escalation. It could be overridden if there are concerns. We've got their own sort of PEWS chart for the individuals who have got their own specific parameters, and we've also got the pediatric sepsis 6 there, and making you sort of think about sepsis, even in the absence of a raised PEWS. And so they say the crucial thing is, how do we manage to make sure that the children are being looked after correctly, and that there is a plan in place? And again, this is from Pat Brady's, that you identify what is wrong with the child, and that's fine, but you also have to think about, what is this going to look like in 10 minutes, 50 minutes, an hour and a half? What interventions are we going to do? Who's made those decisions, and who is going to review the child after a period of time when we expect things to happen, or after a period of time when the unexpected is happening. So it's a lot more than just the sort of simple identification. And in situ training and things has been useful, and this is Ulf's paper from Edinburgh, and he's going to sort of more frequent escalation of care becomes based on staff concerns and a maturing response system. So if the more you getting used to using watcher status and talking about it, then it's likely that with enhanced communication, then people will be picked up and escalated and a plan set more frequently. So we have a very challenging system that we work in. If you look at the ranges of safety in industries, Then we've got the ones that we kind of assume that we are associated with, because there's lots of stuff about civil aviation and nuclear industry and what have you at one end. And then at the other end, you've got mountaineering and professional deep-sea fishing in the North Atlantic, space missions and satellite launches. So have a think for a second about where you think healthcare might be in this sort of spectrum of industries. So from the ultra-safe to the very unsafe. So most people think that it's probably around about the middle, maybe veering off towards the left a little bit. But in fact, healthcare is the only system that covers everything, every base, from ultra-safe, from blood bank, to the very unsafe and chaotic, which is like ICU, trauma, emergency department. So how can we, organize a system that can cover all the bases when we're looking at risk? And the answer is that we have to use the people at the front line to help us. And this is a great couple of slides from the aircraft carriers, and I'll just read it out because it's interesting. So this is more of the sort of the ultra unsafe. So if you want to understand an aircraft carrier well, just imagine that it's a busy day. You shrink San Francisco airport to one short runway and one ramp and gate, make the planes take off and land at the same time, at half the present time interval, rock the runway from side to side, and require that everyone who leaves in the morning returns the same day. Now make sure that the equipment is so close to the edge of the envelope that it's fragile. Turn off the radar to avoid detection. Impose strict controls on radios. Refuel the aircraft in place with the engines running. Put the enemy in the air, scatter light bombs and rockets, wet down the whole thing with salt, water and oil, man it with 20-year-olds, half of whom have never seen an airplane up close. And by the way, try not to kill anyone. So that's sort of one of the levels of the systems that we work at. It's sort of slightly chaotic, unpredictable. We're close to the edge at all the time, and yet our outcomes are actually very good, and we mustn't forget that, that our outcomes are excellent. And so the reason that our outcomes are good is because we are using people at the front line all the time, and that's what happens in aircraft carriers. So taking off from an aircraft carrier is not that difficult. You get slung off the very end at high speed. Landing is different though, and you have to have a big arresting hook at the back of the plane. There's 4 wires on the deck which you have to catch. The first one, if you catch it, that means you're pretty good. If you catch the second or the third or the fourth ones, then you're also deemed as pretty good. But if you're really good and you have the amount of intelligence that you need, then you hit wire 3 every single time, like that guy has just done. And so they do that routinely every time with feedback, with huge amounts of information from pairs of eyes that are allowed to escalate anything at all that is causing them concern. And then you can have a little bit of a celebration at the end as well to celebrate your success. So wire 3 every time is what we're aiming for, but wire 3 every time is mundane. And that means that it's just routine. So what we hope through time is that picking up these children is routine, discussing them with expertise and experience is routine, allowing people to raise their hands when they're worried is routine. And that's partly what the watcher status is about. Okay, so thanks. That will conclude the presentation. So do you want me to hand the ball back, Elaine, or can you nick it?
Yeah, I can take it back, Neil, no problem. Excuse me.
So I suppose, oh, there we go.
Thank you, Neil.
Excellent. So are there people out there who are aware of what a watcher is and the fact that we've been sort of discussing it as it got to your awards, and are you using it? Do people have examples of using a watcher system? And even if you're not, are you thinking about using it? Do you think this is something useful? Did the presentation make any sense at all? I'd be happy to hear from anybody. I can give you an example of watchers in our unit, but I'll just open it to the floor first if anybody has a story that they would like to tell us.
I think Peter's joined us from Lothian as well, so hopefully he might be able to share some of the great work that they're doing around the watchers.
Oh yeah, Peter, are you there? Peter Campbell?
I'm here.
Fantastic.
Both
Peter,
I don't mean to put you on the spot, Peter, so you can either can or
that's
cannot.
exactly what you've just done.
But,
yeah,
no,
no.
but what I was going to say is we're hoping that Peter will be coming, that there's a lot of good work done in Watchers in Lothian, and we're hoping that Peter will be coming to share that at the next networking event as well.
So,
yes,
as you probably know, because you came through and had a visit, we're just in the process of tweaking our system at the moment, because we've used the Watcher status for quite some time now, basically since we started using the huddle. And we're now refining it big time. So where we had a lot of words and a lot of phrases, etc., we're really paring that back now and begin to separate off Watcher from workload, because we found that that was becoming a bit muddled at time and a bit grey. So that's kind of where we're focusing on at the moment, and we're about to go in and start next week in a bit with our test at the moment, where we've really pared down the categories. And we're testing in 3 areas. So we're going for acute medical, one of our acute surgical wards, and oncology, hematology, oncology, because that's an outlying area for us that didn't really fit into a lot of boxes. So they have potentially patients who sit there a lot of the time who are quite sick, but didn't tick a lot of boxes in terms of what was heightened awareness for us. But that doesn't detract from the fact that you've got a patient who's palliative, who may not have a SEPADM, who needs a lot of support, etc. And it's just about controlling that whole thing and making it a very a better outcome for the patient, rather than people all piling in at the last minute and trying to change treatments, etc. So we've been having some big discussions around that kind of stuff as well.
Yeah, and that's really interesting, because we've got the same here, Peter, that there's a lot of Schehalian children that are really unwell, and we don't really know about them that often. We're trying to do some work on similar lines. And I like the way that it's a watcher is not just somebody who is, you know, physically or physiologically deteriorating. There's quite a lot of stuff, as you've said, about the sort of the palliative stuff. I think you do identify people who are potentially at risk or have been admitted with non-accidental injury and things. I can't quite remember how you
Neil,
the watcher.
We did have a category in one of our previous systems where we would highlight someone who was under child protection, but what we were finding was staff were reporting them more for a workload point of view, because could have a child protection case ongoing for 2 weeks, but actually they didn't really need to be in anybody's radar. It was a process that was underway, even to the very hour that they were going home. You know, they would still be declared as a watcher. So we're going to separate them off and put them under a workload line rather than watcher line.
Yeah. Yeah,
because it might be different at the beginning if they come in sick and they're hardened and they need a bit of watching, they're at risk of deteriorating, that will be different. But the fact that they're just in a child protection process line, we'll take them off and put them under workload.
Yeah. And, I mean, what sort of things are you doing with regards, as I was talking in the presentation, it's a communication tool, really, and to try and bring people together in order to make the correct decision for the child at the time. What sort of stuff are you doing, or have you done, or do you propose to do with regards to that sort of communication part of the of this process?
So there's a couple of things that we're doing. So we're working out how we record everything on track, because we've gone paper-like when using the track system. So we need a system within track that we can record where those watchers are and what the plan is, because you highlighted that the plan is really important. So we have a backslash system that we're using, where the staff in the ward can go in and record the category, why they have listed them as that category and what the plan is, and that can be under constant review. And you'll know that the track plans come up in a sort of ward-based type thing.
Yeah.
So you can hover over, we're using a symbol at the moment, and you can hover over the top of that. So anybody who's in that ward or that area who's viewing track can go in and find out why that patient in particular has become a watcher, what level of watcher they are, and what the plan is. So I can sit in my office and do it. I can hover over the plans if I'm looking to see what activities go on in the wards. I can hover over and find out why they have become a watcher. We're also doing that interface thing between nursing handovers or the general bed huddles and the medical handovers, which are 3 times a day. So we're trying to marry up both systems because we did have a bit of a difference between what nurses were recording and what the medical staff were recording. So we're refining that so we're going to work off one system. So we get the big huddle at 8 o'clock in the morning, the coordinator goes to the 9 o'clock medical staff handover, and the day continues from there. So nursing huddle at 3 o'clock, medical handover at 4:30, and then the big handover to Han at night at 9 o'clock, and keep that theme of the watcher flowing through that.
If you're going to give any advice to people who are thinking about implementing a watcher system in their ward, is there any sort of handy tips about how to start?
It's all the usual stuff about people need to want to do it and need to buy into the process. There needs to be a bit of education goes on with everyone who's using it as well. And more importantly, your Band 5 staff nurses, because they'll very often be the ones that will be highlighting the watcher status, because they'll be attending the huddles, etc. So it's you need to be confident they understand what the categories are and why they're listing them under that category, and the ability to separate workload from watcher. So and you know, Neil, we had a big discussion about this yesterday because some of us who are a wee bit older than the two can go back to the 80s and talk about things, because we were laughing because I'd worked in places where they used to have a sick book. Whoever was on for the director at the hospital used to record fairly valuable information on sick patients, but that was what the focus was. It was a focus on who was sick in your ward. And even when you were taught, when you were first taking charge of a ward, that was one of the first valuable lessons that you would get when you came on shift. You know, allocate to all the patients that need to be looked after, but know who your sickest patients are and where you're going and what you're doing with them.
Yeah.
So it's just going back to some fairly basic stuff, but the education part needs to be there, but that education needs to be joined up at the same time as well between all your teams that are working with these patients now.
Peter, can I ask as well, so a lot of conversations that we've been having of late, what you've said is people need to want to do it and they need to be engaged with it, and a lot of conversations we're having with people is around how do you build the will? And did you have any challenges around that, and how did you get around it if you did, or were you just very lucky?
Well, we've been reasonably lucky. I think all ours came from the nucleus of the huddle. Everything came from the huddle. As soon as we started and implemented that and developed that, everything else spun off from it. And people saw the benefit from that, and plus, don't take away from the national PEWS stuff as well. You know, that's been a big help, development of PEWS in itself and the PEWS charts, and making people think about what they're recording. Because it's not just about putting a set of numbers down on a piece of paper. And sometimes we're pretty bad now, those numbers that are recorded are all taken from machines, as opposed to someone at least once or twice during that shift period manually listening to someone's heartbeat, you know, recording respirations, doing a manual BP as opposed to a BP coming off a machine. So, you know, there's practical things like that as well.
Yeah, right, okay.
I mean, we found it very useful for our watcher status on the unit for ECMO. So if there's a child who is, we think, is on the verge of requiring ECMO support, so that's basically a heart-lung bypass machine, typically cardiac children, but sometimes respiratory children, particularly in the winter, then we've gone to, if we make somebody an ECMO watcher, then obviously the bedside nurses know the plan would be to go on to ECMO. So they have got all the drugs that they require drawn up. They've got heparin doses made up. They contact the blood bank to make sure that there's products available. The perfusionists know that there is a circuit available, and the surgeons know that they will be required to come in, put some, cannulas in, and also the echo techs come to find out, do an echo when the cannulas are in. And it's worked remarkably well, and it's just routine now. And it's trying to make watchers and that sort of level of communication routine so that your day is mundane. I mean, putting people on ECMO in a hurry can be fraught, but putting people on ECMO in a controlled fashion because you predicted it is just so much better. It's better for the the staff and the resources that you have because you've anticipated that you're going to need additional stuff. But obviously, clearly, it's going to be better for the patient who is put on in a timely manner. So that's quite an extreme indication or example of Watcher, but it just shows that this can be implemented very easily, and people just now do it routinely, and we almost don't have to talk about it anymore. It's just a routine thing. This person's an ECMO watcher, and then it's broadened out towards other children in the ward who may need to be intubated or go to a different level of ventilation, etc. And it's now just routine language, which is really nice to hear. Is anybody else able to talk about what they are planning or doing? We'd love to hear from you, but if not, then that's fine. I hope the discussion that we're having is useful in giving you some ideas about what to do and where to go next. Leslie, do you have any other questions at all?
No. I was just going to again say, it would be nice to hear from Jackie and Peter if they had anything that they were doing on their units or thinking about doing on their units, and did they have any questions for the other Peter or yourself if they wanted to do that. But if not, as I say, we're certainly hoping that Peter or somebody from his team in Lothian will be sharing in more detail what they're doing at Lothian at the networking event.
I think Jackie had to leave to go to another
so she did.
meeting, so she may well have had some stuff that I maybe blathered on too long.
I always enjoy your blathers, Neil. They're very interesting.
Okay, so I think just to summarize, the Watcher, it's an unusual term. It's got no real, true definition. We've kind of made one up, as I showed in the slides, which is it can be two different things. It can either say who are the children needing expert review, or you can change the E to extra, which is extra review, and that's bringing that sort of expertise to the bedside. Initially, it may well be as part of part of the PEWS chat initially, so the PEWS are getting a little bit worse, but you're still, there's something else about this child. And you're trying to develop that culture within the system that allows you to escalate effectively. And as time goes on, we kind of hope that these sort of words would be used, fairly freely, be easily understood, picked up upon, which will lead to enhanced care of children who are sick, or enhanced children who may potentially become sick, or children that would have just nipped under the radar and surprised us in hours or days during their ward admission, that we can pick up earlier and mitigate and reduce the chance of harm. And as the Epoch study says, that part of the PEWS process and part of that system has maybe allowed people to be picked up earlier and escalated quicker, which is kind of what we're looking at with regards to our measurement plan in the patient safety world in Scotland. Okay, so if there are no further questions or discussions, we might bring that to an end. That's 50 minutes. That was great. Thanks very much, Peter, for your help. He's now gone. And thanks to everyone else